Good afternoon, everyone. Welcome to another session of TMAS webinar. Today we have the Journal Club, and for which we have Dr. Priya, who is a senior resident in JIPMA. She is here to present a journal. And Dr. Abhishek B. Gowda, sir, who is the additional professor in JIPMA Pondicherry, who will be sharing the session and also be
Good afternoon, everyone. First of all, I'd like to thank TMAS for giving me this opportunity for doing this journal club. So the journal that we'll be discussing today is assessing the clinical efficacy of low volume therapeutic plasma exchange in achieving recovery from acute liver failure induced by yellow phosphorus poisoning. So this was published in Journal of Clinical Apheresis in May 2024, volume number 39 and issue number 3. So why have I chosen this study? So basically, yellow phosphorus poisoning is a problem that is very indigenous to India and more commonly seen in South India. And compared to our Western group of patients who will have more of acetaminophen poison-induced acute liver failure, yellow phosphorus poisoning is a topic of discussion. And even though ASFA has updated its guideline in 2023, which has suggested that high volume plasma exchange is a category 1 indication, they've still suggested that low volume TPE is still suggested as a category 3 indication. So the problem statement here is that does low volume therapeutic plasma exchange help in recovery of acute liver failure due to yellow phosphorus poisoning? So there has been few journals which have already been published. One in Journal of Clinical Hepatology, published in 2023, which was done in a pediatric group, which had compelling results where the study involved 32 children and 17 of them had undergone plasma exchange for yellow phosphorus poisoning. And at 1 month, 28 of the 32 children were alive, and they had also suggested that it is an effective non-liver transplant treatment in children with rodenticide-induced hepatotoxicity. Another study by Radhakrishnan et al., which was also published in Asian Journal of Transfusion Science in 23, involving 16 patients, also has suggested that there is significant improvement in the liver function test as well as the coagulation profile of patients who have undergone low volume TP. Now, in the baseline, the benefits that we already know about low volume TP in yellow phosphorus poisoning is that it can be started as an early intervention in the cases, and especially in resource limited setting, as well as it can be also considered as a bridge to transplant or liver recovery. And along with that, the challenges that we are aware of is that the financial constraints as well as the logistics, that is, we need to make available the ICU care, and logistics have to be clear for early initiation of plasma exchange in yellow phosphorus poisoning. So the hypothesis and objectives. Hypothesis for this study is low volume TPE improves patient outcome in acute liver failure due to yellow phosphorus poisoning. And the objective is what is the efficacy of low volume plasma exchange in improving transplant-free survival rate in yellow phosphorus poisoning. So if we analyze the problem statement, that is acute liver failure in yellow phosphorus poisoning, is clearly mentioned. The intervention is low volume plasma exchange, and the control group has received supportive therapy without TP, and outcome is improvement in the transplant-free survival, and it is a case control study. So in the methodology, regarding the study participants, all the participants were more than 18 years. So they have mentioned that they have included all the patients who have satisfied the King's College criteria for liver transplant and also had a positive toxicology report. And in the exclusion criteria are patients with chronic liver disease due to yellow phosphorus poisoning, as well as patients who had acute liver failure due to causes other than yellow phosphorus poisoning, and patients who have alleged history of yellow phosphorus poisoning but have negative toxicology reports, and also patients on treatment for prior history of self-harm. So this is the King's College criteria for non-acetaminophen induced acute liver failure. So that says INR greater than 6.5 or any three of the following criteria, that is patient age of less than 11 or greater than 40, serum bilirubin of greater than 300 micromoles per liter, time for onset of jaundice to development of coma of greater than 7 days, INR more than 3.5, or drug toxicity, regardless of whether it was a cause of acute liver failure. Now, the study population was divided into two groups. Group 1, who underwent low volume TPE. Group 2, who have opted out of LVTPE, and these patients have acted as controls. And both the groups were matched for age, gender, distribution, clinical severity, and ICU admission. And approval from institutional ethics committee was acquired, and consent was taken prior to each procedure of TPE. Now, about the institutional treatment protocol, initiation of TPE was decided by a multidisciplinary team which comprised of transfusion medicine specialists as well as gastroenterologists, and standard supportive therapy was given to all the patients in both the arms, that is N-acetylcysteine, anti-encephalopathy measures, rifaximin, terlipressin, and vasopressors. So the protocol that they have formulated is, when the patient has an altered liver function with hemodynamic instability, with coagulopathy, with or without encephalopathy, the first step is to do 1.3 to 1.5 times the plasma volume exchange daily for 3 days. And day 4, the patient is reassessed. And if the improvement is not complete, 3 more TPE sessions are done with the same 1.3 to 1.5 times the plasma volume on alternate days. Now, the endpoint of TPE, they have mentioned is resolution of coagulopathy, normalization of liver enzymes, no signs of encephalopathy, and 75% decrease in the liver enzymes. And the study endpoint is discharge from hospital or death. The clinical outcome that they have assessed is survival rates, duration of hospital stay, and the percentage of patients with altered LFT or coagulopathy at the endpoint of study. And they've also discussed about the procedural details. They have done low volume TPE with Comtech from Fresenius Kabi, and replacement has been done with 40% crystalloid and 60% colloid. And the 60% colloid was divided in 1:1 ratio with 5% albumin and FFP. And as a prophylactic measure, all the patients have received calcium supplementation with 10% calcium gluconate in 100 ml NS over the procedure. And this is the study flowchart. So the total number of cases with alleged history of yellow phosphorus poisoning was 57. And they have excluded 21 patients with negative toxicology reports, patients who did not require an ICU admission, and multiple attempts of deliberate self-harm. And patients with yellow phosphorus poisoning meeting the inclusion criteria was N equal to 36. Out of these, 19 patients underwent low volume TPE, and 17 patients opted out of low volume TPE. And out of the 19 patients, 13 of them survived, and out of the controls, none of them survived. Now, the outcome variables that they have explained are the survival rate, length of hospital stay, percentage of patients with coagulopathy or altered liver function, and readmission. So moving on to the result, they have mentioned that the overall time delay to admission was 4 days, but it is not separately mentioned for group 1 and group 2, and the range of 1 to 11 days. And medium time delay in initiating low volume TPE was 5 days, that is 1 to 10 days from day of consumption. and 3 days, that is 1 to 6 days from the day of admission. And the length of hospital stay was 10 days for group 1 with an interquartile range of 11 and a median of 4 days for group 2 with an IQR of 1. And in the results, we can see here that the age and gender and the basic demographics have been matched, but there is a slight increase in the age of patients in the group 1, where the mean age is 34 compared to group 2, where the patients seem to be of a lesser age. And in group 1, we can see that there are more number of males compared to group 2, where there are more number of females. But these the p-value is not significant, so we can assume that there is no statistically significant difference between these two groups. And the median interquartile median delay in admission was 3 in the group 1, that is the group that received LVTP, and 5 days in group that did not receive TP. The hemoglobin, hematocrit, WBC count, and platelet count was almost similar in both the groups. And there has been no statistically significant difference among these two groups at the endpoint either. Whereas when it comes to PT, APTT, the PH, AST, ALT, and ALP, there is a statistically significant difference among both the groups at the endpoint of the study. And they've also mentioned about the procedural parameters. So on an average, they have processed 3,226 ml of blood, and number of procedures per patient is 3.47 with 0.9% NS substitution of 1,700 ml and albumin of 944 ml, as well as FFP of 1,900 ml. Moving on to the length of hospital stay, in group 1, it was 10, and in group 2, it was 4, and coagulopathy and altered liver function at the endpoint is drastically different in group 1, where 6 patients had altered liver function at the endpoint, whereas 13 patients did not have a altered liver function at the endpoint, compared to group 2, where 17 of them still had altered liver function at the endpoint. And the percentage change in the parameters are also significantly different in case of platelet, AST, ALT. And the survival analysis has been done based on the Kaplan-Meier estimates. The number of survivors in group 2, there are no survivors. That is, here we can see in the graph that almost all the patients have succumbed to the illness by 2 weeks. And 13 out of the 19 patients in group 1 survived and were discharged, resulting in 68.5% reduction in mortality rate. And there were readmission in 2 cases, which was managed conservatively. One of the patients presented with pancreatitis, and none of the patients had required liver transplant till 90 days from the date of discharge. And the strongest predictor of mortality was either development of refractory shock. Out of 37 patients, 23 of them who died, 20 patients developed refractory shock during hospital stay. And delay in admission or delay in starting LVTP was also a strong predictor of mortality. And in the conclusion, they have mentioned that the results are promising, and TP has to be initiated at the first sign of altered liver function. And low volume TP has to be considered as a first-line therapy in yellow phosphorus poisoning when liver transplant is not feasible. Now, moving on to the critical appraisal of the journal. So in the title, the population, the intervention has been clearly mentioned. The comparison, however, is not mentioned. The outcome is mentioned. The time frame for this particular case is not relevant, and the type of study is also not mentioned. The abstract is very well structured and informative and reflects the contents, and the keywords seem to be adequate for the for searching this journal. In the introduction, they've clearly mentioned the circumstances leading to this research, that is yellow phosphorus poisoning in South Indian population, as well as a lack of antidote for the same, and the socio-economic background, that is poor financial status of the patient and lack of vast donor registry in India, which ultimately leads to a delay in a patient getting a liver transplant. And they have also mentioned about the supportive evidence as well as guidelines. Here they've mentioned about the ASFA guidelines. And in the methodology, even though they've mentioned that they have included all the cases which have satisfied the criteria of the King's College criteria, the sample size of how they have estimated a sample, or was it estimated, has not been mentioned. And in the exclusion criteria, again, ALF other than yellow phosphorus poisoning, why we need not emphasize on such a point, and there is an exclusion of patients with self-harm, which might be because of legal reasons, but it has not been elaborated on. And the consent or waiver for the control group. Again, the consent was taken from all the patients who have undergone TPE, and the same has been mentioned in the journal. But what was the procedure for taking consent or waiver of consent for the control group is not has not been mentioned. The endpoint of LVTP, one of the endpoints that they have mentioned was no signs of encephalopathy, but in the results, there is no mention of encephalopathy, and in the baseline also, there is no mention about how many patients exactly had encephalopathy at the time of initiation of PLEX. And as I mentioned earlier, there is a slight difference in the age and gender, but it does not seem to be statistically significant. But the median delay in the admission to hospital is 3 days in group 1 compared to 5 days in group 2. So this 2-day delay is going to be a very significant factor when it comes to liver failure, where the patient will progress or can progress badly over a few days. And in the results and discussion, the data presentation is very well done, and the result has been substantiated in the discussion part. For example, they have mentioned that the median hospital stay was 4 days in the group 2, which did not undergo low volume TP. But in the discussion part, they have clearly mentioned that most of the patients in the second group, that is the no TPE group, had succumbed to the illness within 2 weeks. Hence, the length of hospital stay is smaller. And the table and legends have been clearly mentioned. The additional thing that could have been mentioned is a dose of rodenticide consumed in each arm. So they've collectively told that on an average, patients have consumed 12.5 grams of the rodenticide as per history. And we could have elaborated more if we had known how much was consumed in each group. And in the LVTP arm, they have also mentioned about refractory shock as a predictor of mortality. So out of the 6 patients who have died in the group 1, it is not mentioned how many of them actually developed refractory shock. And the limitations also, they have clearly mentioned that there is a lack of randomization in choosing the patients. And in the conclusion, it is comprehensive, and they have also justified the conclusion. And the limitations, although were discussed in the discussion part of the journal, it has brushed through all the lacunae in the study. And overall, this is a well-written study, and it can be used as supportive evidence when we are planning on initiating low-volume plasma exchange compared to the current guideline of administering high-volume plasma exchange in patients. Thank you.
Thank you, Dr. Haripriya. I now request Dr. Abhishek sir to take over.
Can I share my screen?
Yes, sir.
Is it visible?
No, sir. It's showing Haripriya's screen. Haripriya, can you please stop screen sharing? Yeah.
Yeah, I have
It's
stopped.
visible.
Yes.
So now it's visible.
Yeah. Okay. Thank you. Good afternoon to everyone. So the appraisal, anyway, Dr. Haripriya has beautifully presented the article. And I also know that some of the authors are here in the meeting. So it's a very positive sign that we all know that no research can be done in the most ideal possible way. And there is nothing like that. So what we have to learn is how things could have been improved, or if you are replicating a study like that, what are the things that you will keep in mind. So thank you, Haripriya, for doing a wonderful job. Scientifically, you have used all the checklist and methods possible. So what I am going to do in the next few minutes is just give a hint or giving you a perspective of how to think about an article and go about it. The first thing is, what is a critical appraisal of an article? So it's defined as carefully and systematically examining research to judge its trustworthiness and its value and relevance in a particular context. So the context is the context in which you are going to use it, and also the context in which the investigators did the study. So why should we critically appraise or read a paper at all? The first is to convert our information needs into answerable questions. That means to say, so the article presented about therapeutic plasma exchange, low volume in a low phosphorus poisoning, whether it is beneficial or not. So now we read any paper to answer our question. What is our question? Okay, if I get a patient of a low phosphorus poisoning, should I undertake therapeutic plasma exchange for that patient? If yes, how am I going to select my patients? And what does this paper tell me or give me a confidence or evidence about the decision that I'm going to make? So any paper, we usually read like that. What are we looking at? If I'm looking at see whether a hepatitis C or E is a problem in my society, I will actually ask a question as to how big is the problem. Then only I'm going to embark or something. Or if I'm going to give a therapeutic intervention or a medication or anything to my patient, I want to know how much is this beneficial. So that is first thing why we do a critical appraisal, to convert our information into answerable needs. Okay, reading journal will give an idea of what the authors have presented to us. But is it going to answer my question? Is one reason why we are going to critically appraise it. Then the second is to combat information overload. That is, whenever I want to read something or look for an evidence, we all know that n number of resources are available, n number of articles, papers, guidelines are available. So now, with such information overload, which one am I going to look into keenly if I am going to adopt something? So to track down with maximum efficiency the best evidence possible or available as per date. Next, third one is to identify papers that are clinically relevant to assess its validity, that is closeness to the truth. Okay, so what they have presented, how close they are to actuality. And of course, the last one is the usefulness or a clinical applicability. So how to differentiate this? For example, I will give an example of, say, a new antihypertensive drug is coming to the market. Okay, and the authors claim that this drug, which is new, will consistently lower the lower the blood pressure, the systolic blood pressure of the patient who takes it consistently by 6 mmHg. Okay, so statistically relevant, everything is fine, and the drug is pretty consistent. Anybody who takes on an average, his BP systolic pressure goes down by 6 mmHg. But now, when I am talking about clinical applicability, am I happy with a drug, however consistent it is, if the maximum benefit the drug is going to give me is a reduction in 6 mmHg? Is that going to be sufficient? What is that I am looking at? Am I looking at a minimum reduction in 10 mmHg or more than that? So that is our clinical applicability, and that is what we have to look for when we talk about usefulness. The other one we generally talk in terms of usefulness is what is known as NNT, that is number needed to treat. That means to say, for example, if I say aspirin should be taken to prevent cardiovascular event in a person more than 55 years of age, the number needed to treat will tell me how many people am I going to treat to prevent one event of stroke or a ischemia that is going to happen. That means to say, if I have to administer to 2,000 people to prevent one stroke, is it beneficial? So that these are few things that we look at when we actually look into usefulness or clinical applicability of the paper. And of course, the last one is continuing professional development. That is particularly evaluate our performance. That is, by critically analyzing, we gain a lot. We'll come to know that what are we doing, is it correct, or how capable are we to actually assimilate or digest the resource or the information that is available to us. Now, with this introduction, going back to the paper, so whenever we talk about evidence, we all say, okay, these kind of therapeutic interventions where we do, it should be a meta-analysis or an RCT for an intervention like this. Now, we should also understand, is RCTs always necessary to prove an intervention or a therapy? For example, when a clearly successful intervention for an otherwise fatal condition is discovered, okay, so RCTs may be unnecessary. For example, we always say, there is a saying in Canada, if you have a wound in your palm of the hand, do we really need a mirror to look at it? No, right? We can directly look into the palm. Okay, something like that. So RCTs are unnecessary when there is a clearly successful intervention and for otherwise fatal condition. Okay, so that means to say, if you want to do an RCT on a fatal condition, you cannot deny the treatment, however less practical or useful even if it is, say, it gives a 10% more survival benefit, probably you cannot withhold to the control group. Okay, so in those conditions, RCTs may be unnecessary. We have a big example of the COVID vaccine. When COVID vaccine was introduced into the field, there were no trials done. Okay, the reason was there was no enough time to do it. Okay, and the second one is doing an RCT may be unethical. Okay, so we have evidence that, okay, 10% of people who are who undergo a plasma exchange in yellow phosphorus poisoning, a survival benefit is probably 10%. But now, are we deliberately going to put people, randomize and put people into control arm? Is a very ethical question, and it's very unethical to do. For example, if you see here, what they have done is people who could afford or willing to take plasma exchange as a treatment, they have given them the treatment. It would be definitely wrong for them to select a person and then randomize him to receive the treatment or not. And that too, when if we see retrospectively the results being so good, definitely it would be highly unethical. People can also talk that, okay, isn't it unethical to not give a treatment just because they were unaffordable? But the problem is this is not done prospectively. It is just retrospectively analyzed to what happened when the decision was taken based on many other things. Sometimes RCTs may be impractical. For example, where the number of participants needed to demonstrate a significant difference between the groups is prohibitively very high. Okay. So now, for example, in the same condition, the presenter, she said that probably sample size, we don't know, since the authors have not committed on how the sample size was chosen. And that's how she said. So, but probably if we prospectively try to calculate a sample size and the sample size comes too high, say 150 patients, we all know that yellow phosphorus poisoning is an accidental poisoning or an intentional poisoning, and many a times with an intention to harm self. And many a times these patients may not reach the hospital. And when this happens, unless for the one who has consumed it, doesn't even know what they have taken. So all these issues are there, and probably getting such huge numbers to design a trial and go ahead with this is almost impractical. So if you see, hardly 2-3 papers, and most of them are a very small number of cases. So that is another thing when RCTs become impractical to use. So for example, I just tried to calculate the sample size, if at all we were planning to do this. This is from a software freely available from Cleveland Clinic. So in this study, presuming this is a case control study, where cases are the ones which received a therapeutic plasma exchange, and the controls were the ones who did not, with a type 1 error, that is confidence intervals of 95%, giving a value of 0.05, power set at 0.8 with one case to control ratio. Presuming that in the control group, say 0.3% people will survive, and in the intervention group around 0.8%, that is 80% will survive. I just calculated a sample size, and this is what the software gave. With correction for the continuity, the sample size is around 90. So if you look like that, probably these people have adequately met the sample size, because actually it's easy to talk retrospectively, because in retrospect, if you see, none of the patients in the control arm survived, and every I don't know, 70%, yeah, 6 of 13, right? So around more than half of them survived in the intervention arm. So probably, however, it would have been prudent if they had just mentioned a line or so in how they decided these many sample size. The reason why I say here is, actually, if you do see the study was only for 18 months. So probably the next question is, was it possible for them to extend a study for another, say, 6 months or another 1 year or so, is one thing which we can always ponder over this one, because since it was retrospective and data was already available, it was just about collecting the data. They could have probably extended the study for a few more months if it was giving them a sizable number. But however, whenever we present, it's always because when somebody reads the paper itself should say everything, because most of the time when we present in a CME or a conference, there is an interaction possible. Somebody can ask you how it was done. Whereas when it's presented in a paper, there are no much opportunities to do that. So it's always better to comment, and these checklists will definitely help. And that is what our presenter was pointing out. The other thing is, I want to tell that everybody should know. We all know that they have used the Kaplan-Meier analysis in this paper. Of course, they could not probably use the odds ratio, because odds ratio does not work when one of the component, that is disease or the in the intervention arm, the one who are affected in the sense here death was 0. So once it was 0, RR or the relative risk or the absolute risk cannot be, odds ratio cannot be calculated. So probably, and they have presented the survival Kaplan-Meier survival analysis. So one thing I just want to tell everybody when you use this is, when we use Kaplan-Meier analysis, this is the one that is used. So we can see, this is just a different example I am just showing. So this is a study where they have studied gefitinib along with the conventional chemotherapy. And they have shown that, say, if you look at 8 months or even somewhere around the 10th month, the difference is huge. Okay. The ones in whom the gefitinib was utilized, the survival was 50%, whereas those in not, it was about 10%. That means 40% difference in the survival when we look at the survival at 10 months. But if we wait for another 10 months and see, the survival was almost, the difference has almost nullified. So now, why this point is very important is, the difference that we show on an analysis is biased by what is the length of the duration of the study. For example, here, if you see the outcomes that they have studied, it is up to death or the discharge from the hospital. Now, the problem is, at least from the paper, it is not clear as to what was the discharge criteria utilized by them. Okay. So once they say the follow is up to the discharge, probably it should have been mentioned somewhere in the methodology as to what was the discharge criteria utilized by them. Because why I say this is, especially in papers where the analysis or the follow-up is very short, we don't know whether the difference nullifies out when we follow these patients up for a very longer duration. Now, we should always take it with a pinch of salt that how much is longer. For example, if you follow up everybody for say 60 to 80 years, everybody is going to die, isn't it? So that is one thing we should always do. So death is imminent. If you follow somebody, maybe after 30 years, all the death rates will be similar. So what I'm telling is, it has to be justified as to what is the follow-up. Okay. And in ones in which a long-term effect is possible, probably instead of looking at the hard outcomes, we should also look at something like quality of life or something, because we all know that, for example, amputation in a gangrene or something generally works well than the antibiotic or the other limb preserving therapies that we use. Okay, so we all know that whenever we amputate early, it's definitely going to be better with respect to the infection and other outcomes that we look at, discharge and other things. But if we really look at the quality of life, that would be much, much different from an amputation when compared to, though the mortality or the morbidities would be much higher, but the quality of life in people who survived will be much better. So always we should keep that in mind in when we are looking into these kind of analysis. And the other, of course, point that brought about by the presenter was about the inclusion and exclusion criteria. Okay, so I agree in part with the presenter that one is they had told that the inclusion criteria was King's College criteria for liver transplantation. But the issue with that is, actually, if you actually look into the King's criteria, there are few little different versions for it. So probably the author should have told as to what exactly they use, because one is one of the criteria in a non paracetamol poisoning is actually what they have told is in the criteria 7 days from jaundice to hepatic encephalopathy. But here, if you see, most of the patients have been recruited, I mean, 3 or 5 days. So I don't know exactly how this criteria was adopted. So what I'm telling is, whatever it is, whenever we write a paper, probably we should not give rise to much inquisitiveness among the readers. Okay, so though they have mentioned King's criteria, probably it would not have harmed if they had at least given a reference to the which one they have used or something like that, or justified. And another small mistake that I noticed is whenever we give exclusion criteria, they should be a subset of the inclusion. That means to say, when you say that the people with a positive toxicology were included in the study, your exclusion should not obviously be negative toxicology study, because all the negatives or the ones who are negative on toxicology has already been, you have not even selected them. Though you have selected only people who had a positive toxicology. So only now we have to tell is among these who are selected, which are excluded. So your exclusion should not usually mirror the inclusion, but rather should be a subset of the inclusion. The same goes with the other thing as well, which they said about the inclusion. So they have said ALF due to other causes than YP. So that is not an exclusion, because your inclusion only is yellow poisoning. Okay, so those were the two things that I noticed and said. And other things coming to the results, of course, the presenter has told them in detail. One thing I also noticed this, if you see in the results section, okay, I will go back to that if Haripriya can, Dr. Haripriya can share that slide. Before that, another comment Dr. Haripriya, the presenter, made is about the ethics, that as to how they took ethics for the controls. Okay, so this is a nice, interesting. I read that bureaucracy stifles medical research in Britain, a tale of 3 trials. So we all know that ethics is very important. Of course, I am not telling that it is not important, but we should also know when we should apply and how much this should apply. For example, this is the retrospective study where no patient interaction is there at any point of time, and in no way an investigator or anybody can be biased, because in the sense there is no direct interaction with the patient whatsoever, and it's a record-based study, and there is no identity of any patient revealed here. So possibly, I don't know, but how the ethics wanted them to do. But that's why I said, whenever we comment, there is no comment in the paper. So that should have been there as to, because by reading through the paper, it looks like the consent was taken for the apheresis retrospectively. I mean, retrospectively when the procedure was done, that is obvious. But as a part of the ethics, did they get a waiver of consent or no is something which we really can't infer from the paper. So, but we also should know that though as a checklist, everybody has seen this and commented, we should also be wary of the fact that it's very difficult sometimes to get ethics for or a consent for everybody. And we should be really look into it on a case-to-case basis. If Dr. Haripriya can share the article, just that result table.
Yes, sir. You want me to project the article or the PPT?
Anything is better. I want that table 2, table 1, sorry. Yes, thank you. So, this is one thing. So, of course, the results have shown that 6 out of the people who got a flex plasma exchange survived, and none in the control group. So that's a very good finding. But only thing we should look into here, if you go into this table here, we see that the delay in admission in the group which received the intervention is 3, whereas the one which did not receive the intervention was 5. So now the issue here is, it straight away says that in the control group, there was a delay in admission by 2 days when compared to the intervention, which may also tell us that probably the ones who got the intervention early had a favorable result. Okay, which is very much of a concern in diseases like this, where the rapidity of the liver failure sets in. 2 days is really a big margin. So this is something which is very difficult to understand by just reading the paper, because if there is 2 days delay in a group where the intervention was not done, is it possible that the or we don't know how much of the contribution is because of the delay itself. So that is one thing I wanted to tell. Other things the presenter has pointed out, gender difference in the group and age difference. Gender, I don't know. Again, the issue is the gender really going to matter in this disease? And the plasma exchange is something we don't know. So unless that is known, it's really hard to comment on that. And coming to the age, of course, she said that almost an 8-year difference can be seen. But also, what we have to understand is the King's criteria, it also takes into account of the age. So less than 10 years or more than 40 years is one of the criteria for King's Institute transplantation criteria. So now, obviously, if you have included that, most of your patients would be more than 40, and obviously your age will be higher from the group 2. But I don't know, I can't comment on this because it is a summary statistics and we really don't know the distribution of the patient population. Then the other thing the presenter said was with regard to the limitation. Is it? Can we go few slides? Okay, not this one, next one. Yeah, this one. So she also commented that dose of the rodenticide consumed in each arm was not mentioned. As a critical reviewer, I definitely agree with what the presenter said, but let us think in the other form. We all know that most of the time it's a homicidal poisoning. So many a times the truth is hidden, and most of the time the history is collected from the bystanders. Rarely ever the history is given by the presenter himself or herself. And even if the history is given by the patient herself, how much can we trust on the history? Because obviously the condition which led them to undertake this precarious step is always critical. So it's very difficult many times to just know what was consumed. And in that scenario, really getting into how much was consumed, and even if they tell how much was consumed, how much should we rely on that is really of questionable value. So yes, it is definitely apt to think like that, but we should also understand that it may not be practically possible. I think with that, I congratulate the authors. Few of them are my friends itself. Happy that the transfusion medicine fraternity has presented one of the not very common condition in a global journal like Journal of Clinical Affairs. I also thank the presenter, Dr. Priya, with of course my student as well, who has done a tremendous job in going through the paper and bringing it in a nutshell for everybody. And also thank TMAS for this opportunity. I would be happy to take a question or two.
Thank you so much, sir. It was indeed a very insightful session, I think, on a very much needed topic. And thank you, Haripriya ma'am, for your presentation. So if anybody has any questions, please unmute yourself and ask, or you can also type in your questions in the chat box. Sir, I think there are no questions. So thank you once again, sir, for on behalf of TMAS for being part of today's session. The recording of today's session will be available soon on our YouTube channel. So thank you all once again until we meet again.
Thank you, Arjun.
Shall we leave?
Sir, am I audible?
Yes.
Sir, I think we have no more questions. So I
We can
think
leave.
there are no questions so far.
Thank you. Thank you.
Okay, sir. Thank you so much. Thank you so much again on behalf of TMAS.